Hello, I'm Dr. Polascik from the Department of Surgery and Urologic Oncology from the Duke Cancer Institute, and today I'm going to discuss how to integrate germline testing in prostate cancer screening. I'd like to break down this presentation into three areas. First, to review the current status of genetic testing in a screening population. Second, to discuss what we have done at the Duke Cancer Institute regarding a prostate cancer screening algorithm. And third, to discuss some of the challenges when integrating genetic testing into a prostate cancer screening model. First, I'd like to discuss the IMPACT study. This is the identification of men with a genetic predisposition to prostate cancer. It's a clinical trial. It is ongoing. A large international consortium of 62 centers in 20 countries evaluating the use of targeted prostate cancer screening in men with BRCA1/2 mutations. The aim is to identify genetic predisposition to prostate cancer and then do targeted screening with BRCA1/2 mutation carriers and controls. And you can see here in the schematic that they begin with annual PSAs, serum and urine studies, questionnaires. They use PSA of 3 as a cut point, and then all these biopsies here basically are optional. The early results show that almost 3,000 men with BRCA mutations were recruited. The Lynch arm of over 500 patients is still ongoing. The prostate cancer detection rates during the initial year of screening was about 2% for BRCA1 carriers and just slightly over 3% for BRCA2 carriers. There was a 48% positive predictive value for prostate biopsy, and 2/3 of the BRCA carriers had an increased prevalence of clinically significant prostate cancer. Now, there were some disadvantages. First, the study was started before the widespread use of multiparametric MRI and targeted biopsies. A relatively small number of men underwent prostate biopsy, and since end-of-study biopsies were not mandated, the incidence of prostate cancer remains unknown. Finally, the vast majority of men taking part in this clinical trial are Caucasian, so we likely have very little information on other racial types. Nonetheless, this targeted screening of men using specific germline markers can identify at-risk men who are more likely to require treatment. Now, the profile study is germline genetic profiling, correlation with targeted prostate cancer screening and treatment, with the primary outcome of association of specific genetic profiles, biomarkers, to predict outcome of prostate cancer screening in men at higher genetic risk. So they have two basic cohorts. They have men with positive family history, and you can see the three definitions that they use. And then they have Black African and Black Caribbean men in this trial. The difference is, compared to the prior one mentioned, is that all men undergo an MRI and a prostate biopsy. So in the Profiles Feasibility study, this included 100 men aged 40 to 69 years old with a family history of prostate cancer who had a prostate biopsy. They found that there was 25% cancer detection rate, with 48% having clinically significant disease. Clearly, this is a higher rate of cancer than the IMPACT trial, since all subjects underwent prostate biopsy irrespective of a PSA level. Now, there's another profile study. You can see the trial right there is recruiting 700 individuals with a family history of prostate cancer. Finally, the BARCODE1 study is an ongoing study in the UK, which aims to evaluate genetic profiling using the known 170 prostate cancer risk SNPs as a means to offer targeted screening for prostate cancer in men at genetically higher risk. In the first stage of this study, they had 300 Caucasian men aged 55 to 69 who underwent genetic SNP profiling, and then they found the top 10% of men in that study who progress to stage 2 of the study, and those men will be offered PSA biomarkers and a prostate biopsy. Now, the primary outcome of this clinical trial is to correlate SNP genetic risk with prostate biopsy. I'd like to now talk about what we have done at the Duke Cancer Institute, as many urologic and practices have been affected over the years, particularly after the U.S. Preventative Services Task Force came out in 2012, stating that we should not be screening for prostate cancer. We had to get together as a group and figure out the way forward. Now, the task force brought up a number of legitimate issues regarding prostate cancer screening studies. First is that it was not representative of a non-Caucasian population. Now, at Duke, 30% of our population are African Americans, so we felt that a lot of the screening studies done on European Caucasians did not apply to these men, and African American men have greater risk and more aggressive disease on average. Second, the PLCO study showed a lot of contamination. As everyone's aware, there was some contamination in the European trial for screening, but not as much as the PLCO group. And the guidance that was given by the task force did not account for the slow growth rate of prostate cancer. And as we all know, when there's insufficient follow-up, you can't really show a survival benefit. And then finally, the task force did not allow any input from prostate cancer specialists who take care of men on a daily basis. The problem was, to the PCP, they had a number of conflicting messages, both as to should we screen, and also if we do, which screening guidelines should we use, because there's a number of them out there. So at Duke, we determined to take a risk-stratified approach to prostate cancer screening. We felt that PSA helps to stratify or predict risk for prostate cancer, but is not necessarily the best detection test. We all felt that PSA screening begins with an informed decision, and our goal was to identify men at high risk for early onset or aggressive prostate cancer, because we felt that these were the men that needed to know they had prostate cancer and seek treatment. And largely comprising this cohort are men of African American race or Ashkenazi Jews, those with a positive family history, particularly for early onset prostate cancer, and those with known genetic mutations associated with prostate cancer, such as BRCA2. So we got together as a multidisciplinary group at Duke, which comprised medical oncology, radiation oncology, urology. We have family practice, primary care, and also a new specialty that we have at Duke, oncoprimary care, along with we have a disparities office, and we all came up with what we felt was a reasonable strategy going forward. So in order to come up with a Duke screening strategy, we also had to make a high-risk prostate cancer screening clinic where we can refer men who had some of these higher risk features. We also felt that based on some of the work done at Memorial Sloan Kettering, that we should get a baseline PSA for men in their 40s, because oftentimes this will predict those men who are likely to have early onset prostate cancer and also be at risk for dying from prostate cancer. So I'm showing just a segment of our screening algorithm for men in their 40s. Again, we called this early risk assessment because, as you know, screening begins at age 55 to 69, but we felt that we needed to identify men in their 40s, so this begins, again, with early informed decision. We have men in their 40s, and you can set your lower limit to 40 if you want, but we looked at 45 to 49. We felt that all PSAs at that age should be less than 1.5. And if they were, we would then resume screening at age 50. But if they had a higher PSA, which was not felt to be due to prostatitis, and therefore we would check it, we would then screen them more carefully. And if they had a very high PSA that couldn't be accounted for by infection, inflammation, we would then move on with another biomarker. This is the prostate health index, but you can substitute this for another marker if you want. And then if it was confirmed, it would be referred to this multi-specialty prostate cancer high-risk screening clinic, as I mentioned. So we launched this, and in the first year we screened 50,000 men. And as you can see here, I'm just showing some of the results for men in their 40s. We increased screening by up to 20% with this algorithm. This generated 1,800 referrals to our prostate cancer high-risk specialty clinic. And we had to be able to evaluate these men as well. What was interesting is we did not increase PSA screening whatsoever. That remained flat. I wanted to say a few comments about screening tests. When screening, there should be a high prevalence of disease. It should be an inexpensive test, easy to apply, should be validated, reproducible, and yield actionable intervention. Now, when we talk about incorporating genetic screening, sometimes at present we don't have enough information to especially field the last one, actionable intervention. And for that reason, genetic counseling will be paramount to that protocol. But we felt that the entry point for genetic screening is the family history. Now, we've also identified certain challenges in identifying the high-risk pool of men. One was family history. A second was race. Race typically is self-reported, and nowadays, oftentimes people will have mixed race. It won't be, one or the other. And finally, there are challenges to identifying genetic predisposition, as has been outlined. So the first challenge was elucidation of family history. It sounds like an easy task, but clearly this is very challenging. First, the clinician doesn't really have the time to take a detailed family history. Second, as a urologist, sometimes we get focused on prostate cancer as the only family history, but in fact, if you want to identify genes and abnormalities, you have to take a complete family history, which is very labor intensive. And third, we didn't feel that we had the structure to do this detailed evaluation, and our EPIC medical record doesn't really support it very well. So we had all these challenges, how to record it in EPIC, how to take it, the time it takes, and all this. Now, one strategy at Thomas Jefferson, they developed an app that can help collect the information on family history, especially for non-genetic providers. The second challenge with genetic testing for prostate cancer is that many patients have pathogenic mutations, but they do not meet the criteria, the current guidelines criteria for testing. And this is an interesting study by Pritchard et al., published in 2016, that showed for those with confirmed pathogenic mutations in BRCA1 and 2, and some reported family history, that about only 11% met NCCN guideline testing criteria. 13% had reported personal and family history that may have, and 16% clearly did not meet NCCN criteria. As we all know, there aren't enough genetic counselors available, and oftentimes there aren't very specific follow-up plans. Finally, there are panels of genetic markers that one can order, but sometimes we tend to focus on certain genes like BRCA2 at the expense of others. So in summary, I think if you want to integrate germline or genetic testing into your practice, it's going to require you to build it. It's going to require support. We felt that having multidisciplinary support by our medical oncology colleagues, radiation oncology, and foremost, our primary care practitioners is vitally important. If you want to embed this in your medical record, it may require some IT support, or perhaps you can have an app that can take a thorough family history, as mentioned. These algorithms need to be flexible and reflect current best practices. We felt that you need a separate high-risk track. And finally, you have to keep reevaluating what you're doing to look for improvements. In the end, at Duke, we have what we think is an average risk track that probably identifies 95% of men, and we have to construct a separate high-risk track for men who have high risk for prostate cancer and clinically significant prostate cancer, as we feel that these are the men we need to identify and get in for treatment. Thank you very much.